Hello, I'm Donal McCauley, and welcome to this Medics Voices conversation. Today we're talking to Deborah Cohen in America. Now, Deborah, when I first asked you to talk, you said, "But I'm not a doctor." So let's take you back. What did you study as an undergraduate?
I actually started out in pre-med, honestly. And in the United States, the gateway to being at a pre-med undergrad is chemistry. And I actually did fairly well in the class. I ended up getting a C and I think surprised a lab professor that I did really well on the final, but it just wasn't for me. It was it was just a much more cutthroat, not kind of the collegial vibe I was looking for, honestly. I mean, I was young and I ended up taking some communications classes that I really liked. So I ended up getting a bachelor's degree, a master's, and a PhD in interpersonal and organizational communication. So I am a doctor, but as my kids like to point out, not the real kind.
Oh no, you are the real kind.
I know, I'm teasing.
So tell me about this communication. Tell me about the career in communication.
Yeah, it as an undergrad, I think it was it, it a light bulb went on around research, honestly. The thing that I most recall about my studying communication, because it's a broad field. There's mass communication and people study how the media affects people. And there's interpersonal communication, which would be, how two people communicate with each other. But the thing that really drove me was an interest in research. And at the time, it was the late night, I graduated undergrad in 1990. This was the time, funnily enough, that I remember in my history where women were protesting the right for choice. And the school I went to was in Pennsylvania, which, like today, still is sort of a state that has both conservative and liberal leanings. And the thing that got me going was a research study to understand how the media, the local, state, and national media were portraying the abortion debate. And I was very fortunate to have some professors that helped me see that there was more research that I could do if that was what my interest was. And they helped me apply to a master's program at the Annenberg School for Communication at the University of Pennsylvania. And there I became interested in health and women's health, but there wasn't really anyone on the faculty that could help me with that. So my thesis is in a completely different subject, but I really became interested in this idea that the way people interact with each other, the way we communicate, is a path through which we collaboratively construct our social reality. And I took a couple years off after that and then ended up going back to Rutgers University to do a PhD. They had more folks that were studying interpersonal communication in healthcare and was really fortunate to get trained by some incredible people to learn how to study both conversation in kind of more detail than most people would ever want to study it, and also understand the kinds of communication that happens in organizations. And I sort of blended those two going forward in a way that I will say I never anticipated.
That's an area that many people don't focus on in medicine quite as deeply as that. So tell us about that research that you did in the early days that fired your imagination.
Mhm. So I was my first job after my PhD was as a research analyst in the Department of Family Medicine at Robert Wood Johnson Medical School, which is now Rutgers University. And I was hired by Ben Crabtree, who was a very well-known qualitative researcher in the field. And he needed someone to analyze a mountain's worth of data that he and Kurt Stenge had collected. And I loved it. And so they had collected, they had done observations and interviews. I think it was at about 17 primary care practices across the country with a focus on prevention. And they had field researchers observe 1,600 encounters across those practices. And they were field notes, so they weren't data that I'd been necessarily trained to analyze, but it turned out field notes and it all came together. I'd been trained to be a good analyst at that point. And so we looked at a bunch of things. We in that initial study, I think one of the topics that, as I recall, emerged as really interesting was the way it seemed like some physicians were able to use an acute care visit to create a window of opportunity to talk about smoking cessation. And we were able to publish some work on that topic. That led to a second study that was led by Kurt Stange. It was one of the first implementation science studies, I think, in this country. I could be wrong about that, but it was a very early implementation science study. And it was before folks called implementation science. So he had conducted a study called Step Up, where he offered practice support to primary care clinics, specifically a practice facilitator who worked with the clinics to help them improve their cancer preventive care. And that trial was very successful. And he got a continuing renewal from the National Institute of Health, I think probably the National Cancer Institute, to look at why some practices improved over that 24-month time period and why some didn't. And that's where I came in. And so I looked at the data that they had collected. He had the quantitative data and I had access to their qualitative data, and led the analysis of that, which led to the development of a model that we still use today called the practice change model. And it really identified sort of four simple areas and sort of the interdependencies between those areas that seem to explain why some practices made improvements and others didn't. And it was internal motivation, external motivation, resources or capacity for change, and how the group was able to see what their opportunities for change were. And we could see how facilitators and other folks in the clinic came together to kind of shape those four areas and how that could lead to improvements in cancer preventive care and how it couldn't. And that was sort of the beginning of, a career.
So let's go back a little bit because I'm really
Yeah.
interested in the interpersonal communication, because that's so much a part of
Mhm.
the consultation in family medicine. Tell us about your studies in that area.
So I was trained as a conversation analyst. And that is so although I was in a communication department, my dissertation advisor, also in a communication department, had been trained in conversation analysis, and that is a sociological discipline. It falls into the field of sociology under the field of ethnomethodology. And the idea is that the way people interact and communicate really are the building blocks of social life. And you can see the actions and work people do by taking a close look at the way they talk with each other. And so there's been a lot of incredible work done on how people do greetings, how doctors' visits are opened, and how the way a doctor's visit is open can actually shape how it ends and whether or not something comes up as the doctor's trying to head out of the visit. If you open a visit with a sort of what's going on, how can I help you today, and a broad question that surfaces all the patient's concerns, you're less likely, research shows at the end, to have somebody say, hey, by the way, I'm having chest pains as you're walking out the door. So my dissertation focused on support group interaction. I was interested in, there had been some things written at that point that had suggested that being a supportive person means being a good listener. And I was curious about that. Maybe it was my own cultural background or my own experiences, but I wasn't sure that was absolutely accurate. And I got permission to audio record 3 support groups. These were psychologist-led support groups for women who were experiencing infertility. And audio recordings were the best I could do. And I recorded their first, their middle, and the last meeting, but I never analyzed their middle and last meeting because their first meeting focused almost entirely on each of them telling what I called an injury story. It was a story about someone who often was very close to them that had said something really insensitive to them about their infertility. And what was interesting about these stories was how interactive they were. So the teller told the story in such a way that by the time she got to the punchline, the people who were listening were actually able to show that they knew what was coming, like, oh boy, here it comes, kind of response before she told the punchline. And they had this very unique way of showing empathy that was not one directional at all. It was much more interactive. And that was sort of the bottom line of my dissertation. And although I didn't study that, it's hard to study that kind of interaction in healthcare. So every once in a while, I will get to the opportunity to study interpersonal communication closely in healthcare settings. That was sort of the beginning of an interest. And I will say, when I am a field researcher, we do a lot of, to the extent that we can, we do a lot of observation in our work. Those are definitely the kinds of things I can pay attention to, but it makes it a whole lot easier to video or audio record.
I can see how that triggered a career. I mean, that is absolutely fascinating stuff. So you carried on and you've done this implementation science work with Kurt. Tell me about how your career then progressed after that.
Yeah, so well, I mean, and I tell this to a lot of folks that I mentor. I finished my PhD around the time I was 28-ish, I guess, and shortly thereafter had 2 little kids. So for a while it was really quite perfect for me to be a research analyst. I did not work full time. I worked 80% time. And that was a good fit for me and my family. I would say about 4-ish years into that, I realized I was doing faculty level work and I was working full time. And the folks around me were very nice about getting me onto kind of more of a faculty track. Around the same time, we had an opportunity, Ben Crabtree had an opportunity to evaluate a national program that was being funded by the Robert Wood Johnson Foundation called Prescription for Health. The National Program Office was being led by Larry Green, who was in the Department of Family Medicine at the University of Colorado. And the way these programs work is the Robert Wood Johnson Foundation sets up a National Program Office, and they also set up an evaluation of that program. And Laura Levitin, who I still think of as the queen of evaluation, was sort of the queen of evaluation at the Robert Wood Johnson Foundation and was meeting with Ben and I about evaluating that national program. Prescription for Health was focused on integrating prevention with a focus on diet, physical activity, smoking, and alcohol use into primary care. And it had 2 rounds of funding. The first round was sort of a let a thousand flowers bloom kind of phase, where the program office funded 22 grantees, and they implemented innovations in their own regions through practice-based research networks often to try to improve those targets. And we evaluated that using qualitative and quantitative data, but there were a lot of sites. The second round, the PI ship of that transitioned to me, and the focus shifted slightly. So instead of having 22 sites, there were 8. And there were 8 sites that were truly trying to have an impact and working with many more practices. And we were monitoring the reach of their programs, the effectiveness of their programs, how well they were implementing. And they were all doing slightly different things. and then pulling those threads together to make sense of what we were seeing in the quantitative data with really robust qualitative data. We were interacting with each of the teams through sort of an online format that we called an online diary. We were doing some site visits. We were conducting some interviews. And I mentioned this program because it kicked off sort of a kind of unexpected thread of my career, which is developing evaluations for these multi-site demonstrations that have a shared target, but provide the freedom for each of the sites to innovate. So what followed Prescription for Health, sort of the big three, there's some other little things that have followed that. The second was then a program in Colorado called Advancing Care Together, where Larry Green asked us to evaluate a program in that state that involved 11 sites integrating behavioral health and primary care, where we did something similar, where we evaluated their outcomes of these programs and really interacted with them in real time to kind of share the data and learn with them as we went along, and then sort of pulled together the qualitative findings. And then subsequent to that, we applied for and were selected to be the national evaluator for an agency for healthcare research and quality program called Evidence Now, which involves 1,700 practices in 12 states, but used a very similar approach to kind of understanding tracking effectiveness, tracking implementation, and then really trying to partner with each of the sites to understand, using qualitative methods, what happened on the ground and why.
Well, Evidence Now, it's a really landmark study. That really, really hit the headlines.
It was a big one. Yes, it hit the gray hair headlines too, I think.
So then this moves on, and then is this escalates? Is this another
Yes,
study?
that is escalates. Yeah.
So tell us about that.
So the Agency for Healthcare Research and Quality, they really had a vision for building infrastructure in the United States for supporting primary care. They've had a, 20 plus year trajectory of supporting practice-based research networks. And they really wanted to start to establish infrastructure across the states and study it for what we have come to call a primary care or healthcare extension. And that's how I view Evidence Now. And I'll tell you about the clinical focus. So the idea of the primary care extension or healthcare extension emerges from the idea of an agricultural extension in the United States. So in the early 1900s, the United States government established the agricultural extension in the US. And what they did was they provided funding to each of the land grant universities in each state. Every state has a state university that is considered a land grant university. They provided them with funds to establish teams that wouldn't do farming for farmers, but would be the education and the outreach and the relationship building to support better farming practice. And it transformed farming in the United States. Some for good, some for bad, like all things. But it really transformed farming practices through education, through outreach, and through research. And the primary care extension or the healthcare extension is the exact same principle for healthcare and for primary care, which is to build infrastructure that supports research, outreach, and quality improvement in primary care. And that idea was built into the Affordable Care Act, but it wasn't funded by Congress. And ARC picked that up. And that is what Evidence Now does. Its target was cardiovascular preventive care. So focusing on the ABCs of cardiovascular prevention: aspirin, blood pressure control, cholesterol, smoking cessation. And they, through grant mechanism, identified 7 grantees that were tasked with working in their own state or contiguous states, like clusters of states, to recruit over 200 primary care practices with a focus on ideally focused practices that didn't have their own internal quality improvement support, and to both do outreach and support to those practices and to study the impact of that. as part of that program, they funded an independent evaluation of it, which we called Escalates, because, and it seems like a silly name, and I'm surprised at how often it is mispronounced, actually. But the idea was that our work was meant to escalate theirs, not to get in the way of their work, right? And so we really designed a very comprehensive mixed methods evaluation that looked at the effectiveness of each of these states, looked at their implementation, and the part of implementation that we could track quantitatively most closely was the dose and intensity of practice facilitation support that they delivered, because they all had that component. And looked at what was going on in each of their contexts. So we made visits to their state, we understood their partners. We were very much in constant connection with each of them, very intentionally, not to replace what they were going to find in their studies, but to try to add another higher level layer to that. And I think we were really able to show what investment in a primary care extension can produce. And how investment over time, some states have had investment in their extension for over a decade, and how those states were really able to leverage and accelerate and help practices that, honestly would not have support without them, really have an impact on their patients. So it was huge. As I said, there were 1,700 practices involved, but the potential to really touch over 8 million patients in this country through their primary care office.
It really is a remarkable piece of work. And when you say to touch 8 million patients, it really tells us how big a study that was. And of course, all that work, to use another word, another meaning of the word escalate, brought you on as an elected member of the National Academy of Medicine. So tell
It's
us
true.
about that.
It did. I had not really thought about those two things at the time. I didn't even honestly think about the National Academy of Medicine as even within the realm of possibility for me, honestly. But that is true. Yeah.
Tell us about that and how that feels.
Well, I have to acknowledge, it is nice to be valued. And I've had a lot of good fortune in my career. One of them is I have a chair currently, Jen DeVoe, who is really dedicated herself to uplifting and supporting faculty in our department. So that is certainly part of it, but that isn't all of it. I do feel like it's nice to have other folks in your discipline or field appreciate the work that you do. And so that was a really nice part of NAM. Perhaps the more important part of it is it creates, folks who are NAM members can decide to do something with that or not. It is a complete volunteer operation, right? So, and often what you are volunteering to do is a lot of work, honestly. So I had the honor of serving on a committee that wrote a report on whole health with a focus on the VA. And that was a couple years of work, which was not led by me, fortunately, because the folks that lead those writing those essentially books carry a lot of extra work. But I was able to contribute to a couple of the chapters somewhat significantly. And I do think that understanding how to accomplish whole health care for folks in the United States, including veterans, is really important and maybe particularly timely right now. To accomplish that for veterans in the US really requires having a more holistic system and comprehensive system, because a lot of veterans don't necessarily go to the VA for all their health care. I also have had the opportunity to, and I continue to serve on a standing committee for primary care. So a few years ago, there was during the Biden-Harris administration, there was a push to try to set up an office for primary care in the United States. Which is kind of interesting because the HHS has HRSA, which is the Health Services, I'm going to get this acronym wrong, it's HRSA, I can fill it in later, that oversees our community health centers and FQHCs. But there really isn't anyone in the government that is looking out for all of primary care, making sure we've got enough doctors to serve our population and really tracking. Now Millbank has funded a primary care scorecard, so we can see that we are losing workforce in primary care, but there wasn't anyone in the government that was truly watching that. And with that push, some exceptional primary care leaders tried to establish an advisory council to this office. The office never came to pass for reasons that I don't know that anybody can explain, but probably political-ish reasons. But the National Academy of Medicine, with funding from a range of different external funders, put together a standing committee to advise and answer the federal government's questions really about primary care. And I am just delighted to be able to serve on that committee. It is led by Mary Wakefield and Lauren Hughes. And we have just done a tremendous amount of really good work just to uplift some important messages around how primary care is valued in the United States. Valued not in terms of its monetary valuation, and how the process for establishing that and how the probably overvaluation of specialty care has made it very difficult to maintain a primary care workforce in the United States. We've brought panels together for the public that talk about training the next generation of clinicians for the primary care workforce. And we are now working on another brief report that will really look at workforce more specifically. So, the National Academy of Medicine is sort of what you make of it. And I feel like I'm trying to make the most of it, because a person doesn't get these kinds of opportunities to make a difference all that often.
And family medicine is very lucky to have you there flying the flag. Deborah, it's been fascinating to talk about your career. I would love to hear more about the interpersonal communication and, from the point of view of family medicine, the media communication. But thank you very much for sharing so much of your time with us today. It's been fabulous.
Yeah, thank you for talking with me.